Good morning, good afternoon, good evening. I really extend my warmest welcome to you all. It's a pleasure for me to be meeting with you virtually this year, hopefully in person next year. I will be speaking in Spanish because Spanish is my native language, but it is also the language most shared in the network that I had the pleasure to represent with Felix Rosenberg. And this is the Latin American network. Before starting formally the session, I will be giving to you some housekeeping information. Please feel free to enter your comments, your questions through the whole meeting, through the chat.
Sorry, we can't hear you anymore.
Okay, you can hear me now?
Yes, thank you.
Okay. I don't know if you can hear something or I need to start everything again.
We could hear you
Okay.
only until about maybe 10 seconds, that's all, before.
Okay.
But everything before was fine.
Okay, I was leaving to you some housekeeping information before starting formally the meeting. Please feel free to use the chat in order to send your questions. You can listen the meeting in English, French, Spanish, and Portuguese. And the meeting is being recorded. That's important for you to know. And all the slides will be available on the IANPHI website. So now we will be starting this session. I think that this session is extremely important. Vamos a hablar acerca del rol de los Institutos Nacionales de Salud Pública.
Institutes of Public Health throughout the pandemic.
La perspectiva de la equidad.
But basically from the perspective of equity in health. And it seems that it's very relevant to say that what is inequality? And there are many possible definitions. However, one that seemed interesting is to talk about one of the unfair inequities. I don't think that any recent event has exposed this unfair inequality that the pandemic has brought to light. This pandemic has impacted everyone. The impact of SARS-CoV-2 is completely unequal to all the different populations and groups that have extreme vulnerability. And when we talk about vulnerability, we are referring to the individuals that depend on informal economy, women, refugees, those that are on the unsettled, the dislocated. All these groups are suffering the impact of the pandemic in in much worse conditions than the rest of the population. Just to give you an example, 50% of the workers in Latin America depend on the informal economy. Therefore, they do not have any kind of social protection. 20% of the workers live in urban settlements in which the availability of drinking water and the perspective of being able to do social distancing is absolutely impossible, regardless of being necessary due to sanitary reasons. And something that was created during the pandemic, which is even more relevant, is the digital gap. 30% of the individuals in Latin America have the possibility of having access to the internet. This digital gap is also a gap in the possibilities of the pandemic, of trying to find other solutions to the situation of the sanitary crisis. This is why today's session is essential, is key, especially for the network I represent, because it's a region that is suffering, as we heard recently in his opening conference, the inequalities that brought forward by the pandemic in Latin America, especially. And this is why I have the pleasure of introducing, and we will have 4 speakers who will talk to us about how they were tackling the perspective of equity in health from the standpoint of the different health institutes corresponding to the different regions of the world. First, I will introduce Natalie Mayet. She's a Deputy Director of the National Institute for Communicable Diseases from South Africa. Natalie will share with us some of her slides. And thanks, Natalie, for joining us. You may share your screen now.
Good afternoon, colleagues. Good morning and good evening to the President of IANPHI, the Executive Board, and to all the Public Health Institute directors and partners. It's a great pleasure for me to reflect on this topic, and I'd like to thank IANPHI for giving me this opportunity. It was indeed for South Africa, with its history of deep inequity, a truly reflective moment for me. In the last 27 years, we've had situations where there were separate entrances for different racial classes in formal healthcare facilities, where medical schools, the intake of doctors was based on racial segregation. So in a largely patriarchal society with a Gini coefficient of 63, we had to navigate our way through this pandemic on an inequitable platform, certainly cross-cutting and impacting on all the 17 SDGs. And the levels at which this inequity existed was at a personal level between individuals, at institutional level, at a national level, between sectors, private and public, urban and rural, regional and global. And the country has tried to address some of these inequities over the past by implementing various principles to address the gaps. And certainly we've been moving as a country towards the national health insurance, which is aimed at universal access and a financing mechanism to address access. However, it's taken us a very long time since the declaration of Alma Ata to move in this direction. A key principle is leaving no one behind, irrespective of gender, race, religious preference, leaving no one behind. And the fundamental principles is a social justice imperative, which focuses on the social determinants of health. And I've highlighted health. It's not the social determinants of disease. And I think in managing this outbreak and reflecting on that, we focused very much on the disease and not on the health aspects. But recognizing also that there's an interconnectedness of health and development, and social development, certainly. So the national plan for COVID, the response in South Africa, and I highlight this in this red circle. The plan is an extension of existing government statutes, strategies, and guidelines to address some of those institutional gaps. But as Claudia has indicated, COVID exposed the cracks and significant gaps in equity. So where the plan was to institutionalize equity, and even in our public health institution, our framework is governed, and our policy framework, the policies related to recruitment, development is all, we institutionalize and focus consciously on equitable distribution of representation of gender, of racial representation. And so there are concerted efforts to address some of the equity issues. But systems are not working in harmony. We've had a whole government and a whole society approach. But that statement is trite when you practically implement this intergovernmental approach across sectors. Certainly recognizing the special needs for vulnerable individuals, such as the older individuals, the poor living in townships and informal settlements, and those with disabilities, the need and the response came much later in recognizing those needs. And where leaders are required to make public health decisions, this, based on evidence, this is a strong role for public health institutions to play, both for the systems working in harmony, the recognition of those special needs, and the leaders making those decisions. So the protection of the entire public must ensure individual liberty, confidentiality, and dignity. And this is a crucial debate that we are all having now at the moment in terms of individual rights, individual maintenance of confidentiality and dignity versus the right to roll out mass vaccination and enforce vaccine. So the issue of pandemic ethics is becoming an increasing space in which public health institutions are going to need to play. We are fortunate in the country that our institution is based in the National Health Laboratory Service as a division, and we serve 80% of the public sector population. So in South Africa, we've just got under 60 million people in the population, with 56 million in the public sector. A significant number of clinics are scattered throughout the country, with 422 hospitals across the 9 provincial structures. But I want to demonstrate this graph on your extreme right, where we are dotted with laboratory capacity throughout the country, 233 National Health Laboratory labs that could diagnose COVID. However, initially in the response, so you have the infrastructure, you have, this COVID pandemic has been likened to a war. You have the soldiers, you have the guns, but you have no ammunition. We could not get reagents to do any of the PCR tests for SARS-CoV-2 for at least the first 2 months of the outbreak. And we were competing in a global space with the same suppliers to get reagents. We had gene experts for TB scattered, ready to do the diagnostics, but we could not get reagents. And that speaks to global equity. Certainly a space that we're going to have to play in as public health institutes as we move along. This very busy slide speaks to the core functions of our public health institution. And this is shared by many public health institutions globally in terms of surveillance, outbreak response, provision of specialized diagnostic services, the research and applied research, capacity building, and communications. And whilst we had good enablers that ensured we could detect and respond to this outbreak, there were certainly many barriers that speaks to the equity distribution at all the levels that I've previously mentioned. So the integration of data systems. Claudia spoke to the digital gap. The digital gap also existed in health services, where a health service had no connectivity to transmit real-time data. The lack of standardization of systems. So in our semi-federal provincial structures, each structure, province, developed a system of surveillance that suited their needs and their resource allocation. So there was no equity in standardization. The data quality issues speaks to a system of poor education for healthcare providers. Our healthcare professionals do not understand the importance of data quality, the completeness of data systems to be able to enable public health institutions to report adequately and timelessly. I'm going to use the example of deaths. In the country, we're reporting just under 90,000 COVID deaths. We know that there are more than 250,000 excess deaths in the country. And this speaks to the inequity of standardization of resources, the poor quality of education, of literacy and numeracy, specifically numeracy, that we're dealing with where healthcare workers do not understand the importance of quality of data. Cross-border outbreak detection and response, and the inequity of being able to have adequate capacity, the standardized systems in the region where an individual would move from South Africa to Zimbabwe to Botswana and across the region in terms of that outbreak response and the field epidemiologists required was certainly an inequitable distribution. I've spoken to the issue around reagents, but the costs and prohibitions related to the importation of equipment, of vaccine access is something that the country continues to struggle with. We do not have a local manufacturer for gloves, gowns. Unfortunately, we're moving towards vaccine, establishing vaccine manufacture. But these are some of the issues as countries that we and public health institutions need to drive the need for the establishment of some of these trade and industry agreements and how important it is for global health security for public health institutions to take on that role. How is our research agenda crafted as public health institutions? It's often done by scientists informing scientists. But we really engage with our communities, with our marginalized groups, and with all stakeholders in scoping that research agenda. This is an opportunity to bring equity in crafting a research agenda. The access to food security. Claudia has spoken about some of the challenges that she has experienced. We've lost 650,000 jobs in this outbreak. So on an unemployment rate that was already sitting in the high 20%, we're sitting now at close on to 50%. Transport, and I'm going to park that until I show you a slide. Transport systems that 80% of our public sector use taxis was seen as super spreader. And the lockdowns encouraged gender-based violence in the homes, it encouraged and promoted poverty, and certainly the merge of communicable and non-communicable disease is something where public health institutes are going to have to advance a research agenda in understanding, unpacking it, and focusing on health. Information literacy. All of our communication, in our country, we've got 11 official languages. Most of our information was in English. And we could not, there are no words for SARS-CoV-2 in some of our vernacular languages. There was no word for social distancing in many of our languages. So how do we empower our communities to make decisions where we can't even communicate and we can't even talk? So empowering communities to make decisions is an important part of a role of our public health institution in building capacity for communities to make informed decisions. Importantly, healthcare worker literacy. There have been numerous articles published where if a healthcare worker is literate in understanding the importance of vaccination, they would promote it. Do our healthcare workers understand the dynamics of vaccine, the complexities of vaccine, and to promote it as an opportunity for capacity building for our public health institutions? I think inequity is often rooted and grounded in resource availability, but not only in resource availability, but in terms of the allocation of that resources. South Africa is a middle income country, but all of our resources and our doctor to patient ratios are located in the urban areas and not in the rural areas. All of the resources are focused on your clinical disciplines as compared to your public health disciplines. So I think these are areas in which we're going to need to explore further as public health institutions. This picture here is the context on the left-hand side, the context in which people live. How do you promote social distancing in the living environment of that home? How do you promote social distancing in a key livelihood vehicle of getting to work every day in an overcrowded taxi? This is not all doom and gloom. And what we've tried to do is make a plan. So many of the borders and ports of entry, and we've got 72 of them in the country, were closed as a result of the lockdown. And what we tried to do is to deploy mobile laboratories to provide on-site antigen testing at each of these border sites. So we installed, and you can see the biosafety equipment. We installed PCR instruments, and they interfaced with the laboratory information systems. These antigen tests are also supported in real time, and all COVID results, immediately a patient gets them, are sent to the individual, so they know the results immediately after they've been tested. These are some of the pictures which show some of the living circumstances in which communities accessed these services, the nature of some of the marginalized communities who accessed. A total of in excess of 1.9 million tests, and this is just specifically antigen tests, were performed on these mobile units. There's 67 of them, and we do plan to use these vehicles for further testing for TB and HIV and cross-border initiatives as we move along. And all the data from these units will be fed into our public health institution for further decision-making and policy-making in the past. So some of the considerations. The lessons that we've learned, and some of them incredibly painful, and some of them provided huge opportunities. We need to translate them into practical actions now. So we always talk about integration of services. We've learned that's not possible, but we need to integrate data. We need to integrate that data to be able to inform those decisions. When we build back, that's been a catchphrase, let's build back better, but we need to build back differently. We need to focus on those social, economic, and health outcomes that are beyond our health sector framework. In our public health institutes, certainly, we have to focus on health diplomacy and science diplomacy, of communicating to address the issues of inequity. Essential health services have taken a huge knock. And as we focus on the recovery of those essential health services, we need to have a renewed focus as public health institutions on mental health, non-communicable diseases, and their intersection. As a public health institution, we've learned that we have to adapt. We have to be more agile, but we also have to track our efficiency of interventions to address the inequities that we face. We need to get involved in healthcare worker allocation, capacity building, and workforce planning. And there are many initiatives that we engage with partners and other institutions to do this. So as a way forward for our public health institutions to address the space of inequity, I propose that we define our next normal. We are in our new normal now, but we need to define our next normal. We need to collectively determine the metrics that will be used to determine impact, not activity. Our focus must be prevention, prevention, prevention on the social determinants of health. We have not even begun to focus into the nutritional space. And this is a huge gap throughout the world. What are the nutritional requirements to help people navigate their way through pandemics effectively? The host, the agent, the environment, we haven't focused on the host adequately enough. What is the cost effectiveness and the cost benefits of the work that we do as public health institutions? We don't have economic capacity in our country. Can we share that resource and build that capacity? And so as we do that, let us collectively define success indicators as IANPHI. I'd like to acknowledge IANPHI, all the Public Health Institute directors who supported us through this, and all the healthcare professionals, both in the institutions and out, who make this platform of sharing possible and who navigate their way through this pandemic diligently and with such enthusiasm. Thank you, Claudia. I submit.
Thank you so much, Natalie, for this wonderful presentation. And let me now introduce Yujin Jeong, Director of the Korea Disease Control and Prevention Agency from South Korea. Welcome, Yujin. You will share slides with us.
Yes, I will. Can you see my slides now?
Yes, we can see them perfectly.
Okay. Actually, my presentation is a bit different, but with the previous speaker. But yeah, today I will share our curious response to COVID-19, and I will address some points on inequality in equity with COVID-19 responses. First of all, thank you very much for inviting me to this annual meeting, and I am very happy to have this opportunity to speak in this meeting. Well, Actually, Korea's efforts for public health emergency preparedness and responses go far as right after MERS-CoV outbreak in 2015. And during MERS-CoV outbreak in 2015, WHO and ROK Joint Mission on MERS outbreak provide some important recommendations, which were early detection, early identification and monitoring of all contacts, and regular provisions of information to the public and prompt information sharing. And thirdly, strengthen capacity of medical facilities, including training experts for infection prevention and control, as well as laboratory. And I would like to say that, I want to say that this previous lesson taught the ROK a lot about how to respond to COVID-19 pandemic. So if other countries have no experience like this big outbreak like MERS-CoV in 2015 in Korea, it would be very hard to respond right after the COVID-19 pandemic. I am sure that. Well, based on the lesson learned from MERS-CoV in 2016, Korean government began to reform its public health emergency preparedness and response system. The reform included making changes to organizational structure and system of our agency too. And the emergency operation centers was established, which runs 24 hours a day and 7 days a week. And efforts were made to foster local field epidemiological officers for early and rapid response. And infrastructure, including negative pressure rooms, was expanded in the preparation for possible emerging infectious disease outbreaks. And other efforts, including development manual on how to respond to emerging infectious disease and strengthen on-site emergency responses, education exercises. And these efforts did help, as I mentioned, Korea to know how to respond to the outbreak caused by infectious disease. Well, okay. I think that the slide, it does not work. Okay. Yes, this here, we are here. And this slide shows the confirmed case trend in Korea. Well, our first case was reported on January 20th, 2020. And with several waves, big waves, now we are in a fourth wave. And as that we are experiencing a big wave. Over 200,000 were confirmed. And with easing social distancing level for the vaccinated, we have unexperienced scale of confirming cases around 4,000 to 5,000 a day. And yesterday, 5 Omicron variant cases were identified through full-length genome tests among the COVID-19 confirmed cases with a suspected Omicron variant infection. So we are responding to the variant with strengthened measures from yesterday. Well, I would like to share our strategy to COVID-19 pandemic. Our main strategy called the 3T strategies, which means testing, tracing, and treatment. What is the very first step to respond to the virus is to find it, of course. So we have set the test method January 2020 at the very early stage of the COVID-19 pandemic. At every stage of big outbreaks, the early detection of confirmed cases and prevention of additional transmission chains are one of the basic but at the same time the key element of the responses. And to this end, 630 clinics and testing centers are available to collect samples for the COVID-19 PCR tests. Also, for the early detection of asymptomatic infection, around 200 interim test stations are available in easily accessible locations such as city squares, subway stations, and parks, etc. In order to increase lab capacity, Korea used existing laboratory network, including the National Public Health Environment Research Lab Institute, which are located throughout the country. Also based on the participation of diagnostic labs in the private sectors, such as private medical labs and hospitals, our testing capacity was effectively expanded during the early phase of pandemic. Next element is 30. Next element of 30 is contact tracing strategy. At the initial investigation step, we obtain primarily information through interviewing the patients, primary physicians, and family members. If there is a missing piece of information or a piece of information that needs to be confirmed by data, the investigators collect additional information using other methods. Based on the information, the officers can identify contacts and classify them as close or casual contacts. And I would like to say a bit more about the epidemiological survey support system for the COVID-19. This is the online system that helps quickly identify the movement of path of the confirmed cases with a function such as transmission route analysis and infection risk area analysis. And in order to improve the accuracy of epidemiological investigations, collecting data from credit card transaction credit card transaction reports, CCTV footage, and cellular phone GPS was conducted when necessary within the scope permitted by the Infectious Disease Control Prevention Law. And this illustrates our strategy of treatment. At the very early stage of the outbreak, every COVID-19 patient was admitted to a negative pressure unit. However, with the rapid rise in the number of patients, as well as in the case of facility rate, we realized that the need to find a way to secure access to critical medical resources for patients in critical conditions or at a high risk of developing serious conditions. So we classified confirmed cases into 4 categories, and the patient in each categories are admitted to facilities appropriate for the level of treatment needed. However, with the surge of the confirmed cases these days, we are using our hospital beds to the utmost. So in order to ease the burden, we are highly recommending home treatment now. The Korean government has maintained a concentrated whole of government approach. The Prime Minister chairs the headquarter meeting, comprising all relevant ministries and the central government, as well as 17 provinces and major cities. And this conversation at the very highest level between central and local governments has been crucial to identifying problems and blockage and finding solutions, and ensuring that the solutions are implemented and adjusted as needed. And we can say that we are in the next phase of the COVID-19 pandemic responses with vaccination and therapeutics. In Korea, over 80% of population got fully vaccinated. And even though there are breakthrough cases, the vaccine has proved its effects. And the protective effects is around 80% of total population. Well, to prepare the next stage, Korea was trying to vaccinate more people. We started vaccination for minors and pregnant women, as well as the booster shot for everyone. From November 1st, the ROK tried to go back to normal by easing social distancing restriction for the fully vaccinated. However, with the Omicron variant, the ROK strengthened the measures in the contact tracing and at the entry point of entry. So it'll take a little bit more time, I think, to go back to normal for us. Well, we have witnessed that the vulnerable groups and facilities are more susceptible for the COVID-19. Well, as we have this vulnerability has pointed out in the previous presentation, but for example, during a month, October this year, 2.7% of the confirmed cases happened in care facilities, psychological hospitals, and these such vulnerable facilities in Korea. And in March, for example, of this year, we had a big cluster of 96 confirmed cases in a foreign immigrant workers dormitory in a certain region in Korea. So also socio-economic and social-cultural impacts are concentrated to the socially vulnerable groups and low-income families. For example, in Korea, the sales of small business decreased by 70% compared to the same period of 2019. And personal bankruptcy increased 10% in 2020 compared to the previous year. And because of the online, online school, the gap between students have compensated study measures, and those without these kind of measures became bigger. And I guess these situations are also witnessed in other countries too. Well, to respond this kind of inequality and inequity inside our country, the government adopted the strategies to focus measures to these susceptible groups in terms of COVID-19 prevention measures. For example, we conducted regular tests for the convalescent hospitals, work care facilities, and psychological hospitals. In the situation where the vaccine rollout was limited at the first half of this year, we vaccinated first for the in a high risk groups, including over 70s, and we expanded anonymous tests and vaccination for illegal immigrant workers by using buses. For example, we tried to raise the accessibility of vulnerable groups. Also, we introduced several financial funds for the unstable employees. These measures were adopted in concerning the social welfare measures. Also, we are witnessing the big inequality and inequity between countries to respond to COVID-19 globally. So, for example, the vaccine rollouts and therapeutic supply are limited for the low and middle income countries, as mentioned in the previous presentation. And we have not only for Korea, but other international communities and other countries tried very hard to share their knowledge. But there are countries who are like of experience for the COVID-19 responses, and not only for experiences, but resources to COVID-19 responses, for example, PPE or test kits, and etc. And well, to overcome this inequality and inequality or inequity, the Korea are concentrating on the measures to provide our resources or knowledge and experiences. We support COVAX by commitment of $200 million, and we try to donate vaccines for neighboring countries. And also, we are sharing COVID-19 responses with other countries in Asian countries, and as well as other continents. Also, I want to emphasize that we have to strengthen. We have to more invest in capacity building for countries with a vulnerable healthcare system, and but via many other initiatives, for example, GHSA. And for the next pandemic preparation, the technical assistance with our counterpart institutes are very important too. Well, so in this course, IANPHI will, I think, play an important role in sharing these kind of knowledges to COVID-19 responses, and as well as make the compensation for the inequality or the gap between countries worldwide. So this is end of my presentation, and thank you for listening today.
Thank you so much, Yujin, for this very comprehensive presentation about all the activities developed by your agency. You have made at least 3 or 4 questions in the chat. I don't know if you want to see them. I hope we can discuss them at the end of the presentations. And now I want to welcome Geneviève Jeong, Chief Executive Officer of the Santé publique France. I think that Geneviève, you will be sharing slides with us.
No, the slides will come from the IANPHI Secretariat.
Yes, I'm on it.
Okay. Thank you.
And so, good morning, good afternoon, good evening to everyone, and thank you very much for the invitation to present on behalf of Santé publique France. And of course, on behalf of all the teams that are involved in the fight of COVID. And I specifically acknowledge the input, more than input, Stéphanie van den Toren, who is the leader of the program at Santé publique France and prepared the presentation. So in the next couple of minutes, I will share with you data from the COVID-19 epidemic in France, showing on one hand how the more socially deprived have been more affected by the disease, especially in terms of case and mortality. And on the other hand, some of the response to fight COVID that we have been able to build with this population and in cooperation with many stakeholders and decision makers involving an inclusive and participatory approach. Next slide. So what this slide shows is based on analysis of the National Surveillance Information System that records all COVID tests over the first year of this exhaustive national surveillance, so from May 2020 to May 2021. And this represents more than 70 million tests that were during this period that were free of charge for the entire population. The three panels show from left to right incidence, positivity, and screening rates, and they are figured or represented according to an index, the urban deprivation index, to the composite index of social social deprivation, and the Q5, so this is represented from Q1, the less deprived, to Q5, the more deprived, on the right of each panel, and the analysis are adjusted for the density of population and also the region, and so that's the red spots. Our results, as you can see, highlight a positive social gradient between deprivation and COVID infection. So new cases on the left, in the middle, positivity rate, with the probability of living in most deprived areas. So the more you live in deprived areas, the more you are infected, the highest positivity rate you have. And at the same time, it shows, so that's on the right panel, that there is a negative social gradient in testing, while all testing was free of charge. And so, the more deprived, the more you live in a deprived region, the less screening you use. So these findings may reflect structural factors in access to care in France, and also a lower capacity to respond to protective interventions by deprived populations. Next slide. Now we are in the next slide, please. Thank you. Now we looked these data are showing the mortality during the period. So the first period, March-May 2022, and the link now with another deprivation index. But anyway, we can also have 5 quintiles and report mortality according to these quintiles from the less deprived Q1 to the more deprived Q5. And so on the figure that is the first figure up, we show that the most advantaged Q1 have the lower mortality, so this is shown by the slope, and also this is comparing excess mortality in 2020 with the blue slope, to the excess mortality from 2015 to 29, so 2019, sorry, average in green. And so this difference of excess mortality is especially high in those regions where the viral circulation of COVID was high on the left panel, compared to regions where viral circulation was lower. So still present in those where the circulation of the virus was moderate, in the middle, and even low. So this is for this panel showing that excess mortality was even more present in those with from the most deprived categories. And on the bottom, the complementary analysis on mortality according to country of birth show that, and that's expected, the mortality advantage of the people born abroad or perfectly known and expected given the healthy migrant effect. But what it shows on the right panel is that this is totally reversed during the year 2020 with a very important excess mortality, and in particular for people born in sub-Saharan Africa. Next slide, please. So what we, another work of, and another survey was regarding, in the Confiado study, a panel of around 4,000 children aged from 9 to 18 years that completed an online questionnaire, and the parents completed a separate questionnaire. And this looked into the experience of children during the first lockdown, giving voice to the children. And what this survey shows in summary is that there is a clear social divide reported with children from the most precarious family who suffered from food insecurity, who had difficult housing conditions, and especially no capacity to isolate themselves, who did not have recreational activities with their relatives, and who lived also in isolated communities, suffered the most from psychological distress. And that was evidence with children's psychological distress scale. And this study, for example, has been used in to advocate for the reopening of schools, has been also used to in discussion with the decision makers to consider vulnerable families, and especially those with single parents, concretely in the application of decisions, and also for the development of a partnership with UNICEF. Next slide. So in terms of response, what we used was a general inclusive framework that was developed and deployed. And this is one of the lessons learned from COVID, as we did not have previously so much used that type of framework. So it pushed us also to develop more response towards this population. This approach has mobilized knowledge, and especially between field actors, decision makers, and researchers in a very inclusive inclusive activities at different geographical levels, so not only at national level, but also regional or more local levels, and also included or involved disciplines on to fight against COVID-19 among populations. And all the actors choose, based on the previous results, choose two topics that they felt were especially important. The first one was on screening, and the second on vaccination. So I show you the example for vaccination, and especially showing that these the different factors or determinants that are facilitators or inhibitors for vaccination, and showing also that there are two aspects that can be differentiated: the initiation of vaccination and the completion of vaccination. So the determinants might be a little bit different. So, for example, the factors that are facilitating vaccination for primary vaccination was that the fact that the vaccination was performed following screening, the proximity of the vaccination site, and the limitation of a waiting period, and also the fact that the vaccination was promoted based on a community commitment. But there were also factors that hindered the process, and especially, of course, the competitiveness of needs. For the families, it's more important to get access to water, to food, etc. And that's basic needs. If they are not considered, vaccination comes after. And for the completion of the vaccination, so the second dose, the fact of being accompanied with a close follow-up by a nurse, the fact that to have services proposed in addition to the vaccination or financial incentives were positive, while the threats of expulsion hindered the completion of the second dose. Next slide. Thank you very much. So in terms of response also, the Institute conducted specific actions specifically on vulnerable populations on a health mediation plan for complex cluster investigations. And I show you the report that is available publicly in French. Also training was offered to the mediators in the field to take into account their specificities, and especially sustained attention to living conditions because of the fear of stigmatization, the broad definition of the place of living, and also the possibility of isolation that might not be so easy for some of the communities or population during the investigations. Also, information and communication tools were made available that relied, of course, on trusted community relays, allowing the specificity of their needs to be taken into account. Next slide. And so that is shown, sorry, again, in French, but that has been also translated in many languages. The mobilization of knowledge on vulnerable populations has allowed us also to facilitate that type of building tools with the populations themselves that can be adapted to their needs. And also that was for some of these partnerships, the start of new partnerships during the pandemic, but that can also, based on the confidence that has been built, be enlarged to other health aspects. And especially now that what is built is more interventional research with all the actors in the field, researchers, but also representative of some of the population to also implement interventions that are adapted to their needs. One of that's not research, but I need to mention one thing that with direct communication with the ministry, the social security, and also this population was felt very efficient, was the fact that through these activities of communication, of permanent communication among those groups, social security number has been created for people without health coverage, so that they have access to vaccination in a reactive manner without having to pass through all the bureaucracy, for example, because vaccination was felt far more important, of course, and also a level for confidence. So next and last slide. So to summarize, this program at Santé Publique France has evidenced the consequence of the COVID-19 epidemic. And I show you some of health indicators, and there are much more, of course, that are linked to social inequalities, and including inequalities among people that are born abroad. And especially also shown that children and young people were also affected by the pandemic, though not through severe case, for example, that affected by lockdown and other decisions or interventions that may affect their mental health and development. And of course, those people with precarious housing situations, or those that have suffered probably the most. In these pieces of work have enabled us to make a case with all the actors and the representative of this population for taking better account of social inequalities, and to develop also approaches for mobilizing knowledge, of course, scientific knowledge, but also knowledge from the field. So between researchers, decision makers, and stakeholders, so that the specificities of these populations in an inclusive, more inclusive approach to build solutions is important and relevant to the needs of these specific populations. And of course, that's this continuum that we feel is very important with the integration of our missions in public health, but also with the different networks and the different communities. And that's only, of course, the start, but we can build on this also for the future, and in this to still fight against the pandemic of COVID, but also in terms of health more globally. Thank you very much.
Thanks a lot, Geneviève. This has been really wonderful. And I want to invite now Natia Skhvitaridze, advisor of the General Director for Global and Public Health from the National Center for Disease Control and Public Health from Georgia. Natia,
yes,
you will be sharing your slides. And Natalie, you have questions in the chat. I don't know if you want to start answering them, or we will wait to the end of the presentations. Go ahead, Nadia. Thank you.
Thank you. Dear colleagues, I'm really delighted and appreciate this opportunity given from the IANPHI Secretariat to talk on behalf of the National Center for Disease Control and Public Health of Georgia about our experience to respond to COVID-19 from the perspective of health equalities. Next slide, please. To start with, I would like briefly to introduce some facts about Georgia, a country of South Caucasia. Georgia is a developing middle-income country, and some important characteristics are presented on this slide. Over the last decade, health sector has changed dramatically, improved quality and embraced evidence-based medicine. Transformation and progress reflected in the improvement of health and particularly public health care. Namely, Georgia has strong commitment to improve health of its citizens and the performance of national health system, prioritizing universal health care, initiating several actions for policy improvement concerning to ensure timely access to affordable, preventive and curative health care. Next slide, please. In fact, the main value of the country is the protection of the population, maximum prevention and reduction of harm. That's why Georgia began to prepare at the early stage of pandemic. The NCDC started testing for COVID-19 on January 30, 2020, and on February 26, 2020, Georgia announced the first confirmed case. Next, please. Notably, containment measures the government imposed in the spring 2020, along with the steps it took to overcome the crisis, helped to mitigate the negative effects associated with COVID-19. However, due to various factors, the increase of new coronavirus cases in Georgia began to rise in fall 2020, leading to massive spread of infections throughout the country. Increase in incidence and other critical epidemiological parameters have led country to reach to the red alert. Nowadays, Georgia is recovering from the fifth wave, and COVID-19 is among top 5 leading causes of death in the country. Next, please. And now I'd like to mention that according to national protocol, all officially reported COVID-19 cases are tested either with PCR or antigen testing technology. Initially, testing took place in only 4 labs, but later available sites were expanded to improve equity and consider geographical accessibility. Nowadays, more than 60 labs are engaged in the COVID confirmation. Next, please. Next point I would like to mention is that NCDC is the main organization responsible for countrywide vaccination and immunization. Thus, NCDC was engaged in the development of the National Strategic Plan and operational activities to obtain and deploy vaccines against COVID-19 in Georgia. Country actually started vaccination on March 15 this year. So far, a little bit above 35% of total adult population are fully vaccinated nowadays. Next, please. It is noteworthy that at any stage, the main value of the country is the protection of the population, maximum prevention and reduction of harm. Therefore, health-related issues are on the agenda of all sectors. However, more efforts are needed to ensure that none from the population is left unattended and alone in the fight against this infection. Consequently, the approach leaving no one behind is relevant to achieve goals, and more attention should be ensured to improve the capacity of the health sector. Right now, an assumption for country's response is to plan measures in the fight against coronavirus to maximize equality and access, and is based on the following principles: maximum consideration of interest of the population and civic engagement, guidance by scientific evidence, equity and equality, transparency, and multi-sectoral coordination. And actually, focused on response includes to strengthen capacity of the health sector to meet the challenges caused by COVID-19 while maintaining system sustainability. Next, please. Important to note that to mitigate potential harm associated with COVID-19, to provide timely response and to ensure stability, the government of Georgia has initiated an effective multi-sectoral collaborative work at the early stage of epidemic in country. And in January 2020, the government adopted special decree and established a national intersectoral coordinating committee, highest responsible body for the crisis response at the national level. Under the operational response plan, each participant ministry and governmental entities have clearly defined role and responsibility of the COVID-19 response. And NCDC is a member of this committee. Next, please. As you can see from the slide, under the responsibility of the NCDC is to ensure surveillance, administrate countrywide lab registry and immunization portal, provide countrywide seroprevalence studies to enhance capacity building, support workforce development, and so on and so on. Next, please. And now I'd like to draw your attention to the list of priority groups who are eligible for COVID testing in the frame of state program. That means that this is easier access for them, free of charge, and this list is quite comprehensive and ensures access and guarantees equity for specially determined groups. Next, please. Another example is the risk communication, which have been activated during pandemic and social media campaigns. Campaign was promoted through the various social networks and international evidence-based educational materials developed by WHO, CDC, ECDC, and others have been adopted. Visual materials, educational posters, infographics, videos, all of them are being produced and distributed through various different channels as well, including on the language of country minorities. Daily governmental briefings from the beginning and now at least weekly are provided. And it's also, we activated special hotline at NCDC. In a country provided regular online briefings for the civic society. Additionally, I would like to provide other examples as we have kind of bi-weekly online webinars for all media representatives. And for information and persuading people to go for vaccination, regular live sessions were organized on the center's Facebook with the participation of field experts. Online meetings are held for employees of various organizations and so on. So we have quite a important role to persuade people and engage them in all these activities. Next, please. In a frame of national COVID vaccination program, jobs are free of charge. Universal access to all age groups above 12, including booster dose, is available for them. Also, we started with the most vulnerable groups as elders and from strategic field workers represented by healthcare sector representatives, particularly frontline workers. All Georgian citizens having freedom of choice to choose among various vaccines administered in country. Moreover, for more equity and availability, country created mass vaccination sites, vaccination buses for remote area residents, and mobile groups for people with disabilities and limited ability. For the last period, also is organized countrywide vaccination marathon to promote acceptance, to reduce vaccine hesitance and improve access to this service. Next, please. Now we have come to the end of my presentation. In brief, I had shared experience from Georgia, how we're working to reduce inequalities for this very special time of pandemic. For a final remark, I want to finish my talk with the nowadays very popular phrase, well, we are all in this together, as pandemic do not respect national boundaries. Only a united front stops a pandemic. And please, my final slide. So that's all I wanted to say for now. I look forward to and appreciate your feedback or questions. And once again, thank you and have a nice day.
Thanks a lot, Nadia, for your presentation. And I have been looking at the chat, and I don't know if it is possible for Natalie to answer Anne-Catherine's question. Do you think that you can expand on your answer to this question, Natalie?
Thank you, Claudia. So I think there's a wonderful document that I've posted in the name in the chat. It's a guide to global health diplomacy by Ilona Kursbush and colleagues, and it speaks to the issue around the politicization of health and how science really needs to engage with the political counterparts in informing health policy decisions. And I think it's important that we build that capacity within the public health institutions. Certainly, we have found our scientists had to engage a lot more at political level. Thanks for posting the link, Patrick. So our scientists had to engage a lot, a lot more in depth in positioning what's required, providing the science, and making the business case for buy-in for some of the policy decisions. Now, not always are these recommendations taken up by the politicians, and some decisions that have been made very recently are evidence to that. But I think it's important that we find policy coherence of the science and political diplomacy, and how we balance that. And I think there's an opportunity for capacity building for public health institutions, scientists to be able to engage at that level. I hope that answers the question. It's a very good read, a very good document, and I think it does give some insight into some of the challenges that we face ahead. I think it doesn't only speak to diplomacy in terms of political and science, but also in terms of engagement with other stakeholders and communities. So I hope that's answered the question. Thanks.
Thanks a lot, Natalie. Well, Dr. Yujin has been very kind to answer all the questions because her presentation has been very motivating for the group. Thank you so much for doing that. But I don't know if before closing the session, Duncan wants to say something. You promised that at the very beginning of the session, Duncan. Are you there?
Yes, oh yes, I'm just finding the right button. Claudia, that was excellent. These were four very insightful presentations that speak to the diversity of the world in which we live, but the different contexts in which everybody's operating, starting positions, but also the commonality of the issues that we face and the learning that we need to take forward on this. Natalie's comment about politics, diplomacy, science and public health, I think, is really pertinent, and how we ensure that we can bridge the science with the decision makers and be in the room and be wanted in the room as part of these judgments. Not that we win every argument, because it's a spectrum and a balance, but that we get heard. This is a skill set that isn't common well, I'm not going to put a number, but it's not a common skill set, and yet it's so vital in winning the argument. And we've had this conversation many times about politics and public health and how inseparable they are. And some of the comments also in the chat box were brilliant, and particularly about ethnic coding, I thought, as well. But generally, there's a lot there for us to think about. And Catherine also has been communicating with me separately about the declaration that we'll be speaking on tomorrow, and whether we need to really think whether we got that wide enough in what we understand by inequity and the different perspectives, because each of you this afternoon have contributed thinking that we'll want to reflect. So a big thank you, and Claudia, that was very well moderated, and thank you to everyone for their contributions. And we'll be signing off in just a moment to start again in half an hour. So hope to see everybody again then. Back to you, Claudia, for the final word.
Thank you so much, everyone. It has been really a pleasure for me, an honor to be able to moderate this session with these 4 leaders, key opinion leaders of the public health of the whole world, representing different regions, different strategies. And for what I heard today, I think that every region has developed different ways to track, to monitor, and to know about the health inequalities in their regions. But for sure, we need to improve, and we can improve the surveillance systems. We can improve the way to collect the data, as Natalie mentioned. We can work all together, but we can share all the data and make good conclusions about that. And my proposal is to include all the proposals that you have included in your concluding remarks of each of the talks in the declaration that we will be discussing tomorrow. I think that the declaration is wonderful, but for sure it will be an enriching work to add all these proposals. Thank you so much, and have a nice rest of the day.
Thank you, Claudia. Thank you. Thank you, everyone.